I have Laura with me today, and I'm so excited to have you here. And I met Laura a few years ago and knew that I would be calling her my doctor for that point forward. Because my experience with Laura has been that you walk in the room and she offers a presence of, how can I help you today? And really right from the beginning made me feel like I was in control, but she was the expert. And so I really appreciate that. And I think that many people would agree with me who probably see you. But let's back up. You're here with us today to talk about menopause. And I'm just gonna throw this back to you and say, please tell us a little bit about who you are, what your background is, and then we're gonna jump into this really important topic. So thank you.
Thanks, Natalie. So I'm Laura Murphy-Delos, and I'm a certified nurse midwife. I've been in practice for a little bit of time here, over 30 years. But adding menopause as a regular component of my care is a newer feature. I became certified through the Menopause Society about a year and a half ago, and started offering specific menopause care during that time. But as my own patients sort of aged into this need, it became apparent to me that I had a deficit in my own understanding, and largely that's true of most of us healthcare providers, because this topic has sadly been pretty neglected in healthcare education. So I did seek out that certification, and I'm now providing menopause care a couple days a month through the university. So, and I also greatly appreciate our relationship. I find that one of the things that makes me successful, and you probably find this too, is the things I learn and that from my own people that I take care of. And I think when we, engage in listening and hearing what people have to offer, we can just do better. So, and I didn't get my workout in this morning, so you're seeing me and my commitment to knowing I have to go home and get that done afterwards. So pardon the very casual look, but
I love it. She actually didn't realize we were recording this morning, and she was still willing to jump in with this, and that's a perfect segue because we have to prioritize those things. And so really I think it just keeps things real for all of us, and says, yeah, that includes you who working with patients. You want to get your workout in too. So sorry to interrupt.
Yeah, no, exactly. So
all right, so let's jump right into it. We have a few questions, and this is just kind of a preview interview. Laura's going to come and speak at our clinic, my clinic here, Motion Matters Physical Therapy and Wellness in North Liberty next month. And the information about that can be found on the website, ptmotionmatters.com. And she and I are also talking about the possibility of creating or scheduling a screening of a new menopause documentary that has come out, and we're talking about maybe having like a screening of that here with perhaps a panel discussion where people have an opportunity to ask questions. So stay tuned for more information on that to come. But let's jump in with the questions. So first of all, menopause. Some people experience issues and some people have nothing. Why? Why is it that some of us think our life is ending and others are like, no big deal, we didn't even notice?
That's a great question. I think as in all phases of our life, and there's no decade of our life where our hormonal situation, our menstrual cycles are completely static, and when we're in our reproductive age, right? So that your periods were a certain way from 20 to 30 may not be the same from 30 to 40, and certainly not 40 to 50. The ovaries, especially during the perimenopause phase, are not reliable, and they are releasing not as controlled amounts of estradiol as they maybe did earlier in time. And some of us are just simply more sensitive to these hormones than others. Certainly having prescribed combination birth control for so many years, I've definitely seen that, where I can take 5 people, put everybody on the same pill. Everybody has a little bit different side effect. Maybe someone thinks it's great, it's wonderful, I don't have anything, and the next person has terrible breast tenderness. So that it has taught me through the years that we all have a very individualized response to how our bodies react to these hormones. And it also a little bit like or pregnancy, if you all have ever been pregnant, right? Like you have those friends who never had a minute of morning sickness, and then there are those of us that were very impacted. So I think it's just we're all individual human beings and deserve individualized treatment because of that.
That makes complete sense, and I don't know why I didn't think of it like that before, but in a parallel world with the chronic pain world, or with pain, we have nervous systems that are more sensitized in some people for various reasons. And so I guess that, I don't know why I didn't think of that, but that makes sense, that you'd have the varying responses in the nervous system to the endocrine or the hormonal changes that are happening within the body.
Absolutely.
Yeah.
And I think, I tell the story often that I can remember where I was in nursing school, which lecture hall I was in when we had our lecture as a young 20-something on PMS, and kind of nudging my colleague next to me, my classmate next to me, and being like, well, this is a bunch of whatever, like who has this? And boy, did that come back to bite me in my 30s, because I think also our serotonin levels, like all these things are so intricately tied together. And when we add layers of stress, anxiety, lack of sleep, inflammatory markers, when we're not able to meet our sort of good health behavior needs, poor diet, and people can have all those things working well for them and still have impact of how those hormones play out in their heads. Because estradiol and progesterone and testosterone are manufactured in our ovaries, this whole management of perimenopause and menopause has fell into the laps of us in the OBGYN midwifery world. But really, we have these hormones in every cell of our body, and it really takes a whole body approach to help manage it for folks.
Yeah, well explained. That kind of is a great segue to the next question. So we get a lot of people trying to figure out when to ask their doctor about hormone replacement therapy or menopause or perimenopause type symptoms, and when to ask for testing. And it seems that sometimes either we're not heard, or we're brushed off in terms of testing is just a snapshot of a moment in time for hormones, so it's not worth it. And then you have the other side of folks who are like, we're going to test it all, and here's what you have, and you're deficient in this, and you need that. So, how do we figure out when to ask about perimenopause and menopause, how to get a doctor to listen? These are a lot of questions all in one, sorry. And should we have our hormones levels tested or not?
Sure, all great questions. I think as a good basic resource, there is a new book out by Mary Claire Haver that I think lays out a lot of this very well in a very understandable way. And one really nice thing she does, Jen Gunter also has a great book out there. So there's several good.
Is that the Menopause Manifesto?
Yes.
Okay.
Yes.
And Mary Claire, I think I see her a lot on Instagram, probably TikTok too. I'm not on TikTok.
Exactly, and hers is the new menopause. So both of those are excellent resources with good, sound, scientific information. And I do like that they list all the symptoms, because, we've just too long been like, this is all just hot flashes, boom, that's it. There's a page full of symptoms that go along with this because our whole body's affected. So the testing piece I know there's a lot of controversy, and I have this conversation every day because people come in saying, but don't I need my hormone levels checked? The simple Western medicine answer to that in 2025 is no. There is no standardization of hormone levels that I can say, oh, your estradiol is this, then I need to treat with this amount. We treat by symptoms. We start with the lowest dose possible of the hormone. We use it transdermally. We're using a micronized bioidentical estradiol. So there's no reason that we need to be thinking about other products when we have good, safe, well-regulated products, and at least for the estrogen and progesterone side. And so we really manage, as I said, based on those symptoms. So the blood testing, when that can be helpful, is especially when we're helping folks with things like low libido and we're thinking about adding testosterone, then a testosterone level can become important and very helpful to know where we're at with that, and also with a sex-binding hormone globulin, because knowing where that is can help me understand how well someone might respond to testosterone use.
Okay.
There is no FDA-approved testosterone for women, and so we are left with using the male FDA options that are out there, and or that is a situation where we may have to look at some sort of compounding option through one of the compounding pharmacies. But when I am using testosterone in that way, then that is a situation where I would check a level at the outset and then follow it, because testosterone can have some unwanted side effects that can be irreversible, like enlargement of the Adam's apple, deepening of a woman's voice. Also can have acne, hair loss on the top of your head, hair growth on your face. Those three things are reversible, but the other two aren't. And so that is a place I would use blood testing. But within the purview of providing perimenopause and menopause care, in our menopause clinic and all the other academic centers, we are not using blood testing to guide our management.
Okay, and it's interesting, because I think you definitely hear such a huge variety of opinions on that, and so I appreciate that perspective that you have to offer, and hopefully, we can just kind of take the pressure off some people with that perspective too, to say, just take a deep breath, save some money, just pause for a moment, and keep educating. Yeah,
I mean, I had someone come in recently and she was buying all these things online, paying upwards of $100, $120 a month for all these products she was getting that were not FDA approved products, and they were estrogen and progesterone. And when we looked at that, and I said, hey, I have products, you have insurance that will cover these. What do you think? Do you want to try switching? She's loving that the products are working great for her, and she's saving herself money because they are covered on insurance. Most of the time with estrogen and progesterone especially, there is pretty good coverage for those things until women get into Medicare age, and then it gets a little trickier. But they also have come down in cost. What is harder to get covered and have people use is when we can't use hormones. Those medications that are newer medications and can be very, very helpful, but they don't have a generic version, so they can be costly.
Okay. So what about the issue where we find it's hard to have healthcare providers believe your symptoms could be related to menopause or perimenopause? I know personally I've seen some younger patients with quite a few comorbidities, and I have wondered whether they are in early perimenopause because of the cluster of symptoms that they presented with. And so I've encouraged them to go back and bring that up with their providers, and their providers look at them like they're crazy and won't even hear of it. But I think that there is value to listening and to saying, well, wait, some of this could be an early onset perimenopause with the comorbidities occurring within this particular patient population, or just anybody who's going through it. How do we get that attention to say, please validate something?
So I think, classically we think about perimenopause being about a 7 to 10 year adventure ahead of menopause, which, you get the menopause crown. I joke that we ought to have an award that you get when you
We
come in
should.
and tell me, like,
A
I'm
medal,
here.
and
Yeah,
we can
a
hang
little
on the
medal.
wall.
Because we can only say we're in menopause when we've gone an entire year with absolutely no bleeding. So everything leading up to that is perimenopause.
Okay.
Okay. And
So pretty much after you're done having kids, if you had kids, between then and after you have a year of no bleeding.
yes.
Is that right?
Yeah.
Okay.
Yes, exactly. And so this is that time when you are starting to see that, sort of variation in how much estradiol is getting released. You're adding on that typically in this part of our life, many of us, our stressors are very high during those years as well. So now our request of our brain serotonin is, and all those factors is ramped up. And it's this sort of, I think what I'm seeing is that women probably are entering into maybe a primary care situation, or even, whatever care they're getting, coming in with what might be some perimenopause symptoms that are also, they have a lot of crossover to, is this anxiety? And so what is the best first line to treat? And a lot of people are getting put on medications to treat the anxiety, which are great. I have no issues with using these medications. They're life-saving for many people. They do have some downstream consequences though. So, really finding someone who will sort of listen to those symptoms and understand, like, this could be some perimenopause, and is the best approach to go, do an inventory of the anxiety level, do the right inventories to screen for depression, look at some of the other things that could be going on in people's life.
Lack of sleep.
What's their thyroid doing? What's their diet like? All these things. So getting a whole system, whole person approach, and then thinking through, should we think about premenopausal hormone therapy? Is this a situation where suppressing those ovaries and getting rid of this sort of wild estradiol ride might be the answer? Or is this something that would be better managed with something like an SSRI, more of a mood medicine? So I think those are kind of the things that I'm listening for as I see folks. And I think, yes, I think menopause is having a moment. So I think there is a much greater awareness, and I'm seeing a lot more referrals come in from my primary care colleagues who, are recognizing these things. I think it's also important to just recognize that, from the time we start our periods, we're sort of marketed to that our hormones are bad, our bodies are broken, there's something wrong with our hormones. And if I could do any one thing, it would be to rewrite that script.
Yes.
That our hormones are actually pretty amazing. And yeah, they fluctuate. And yes, we have to learn to live with those, but they aren't breaking us. And there isn't something necessarily the matter with us, but we may need some help at specific times in our lives, and we may need to, do some treatments or change some lifestyle things, but we're not broken. And that is probably the hardest thing for me to hear over and over is, I'm broken. Something's the matter with my hormones. And I just think that that's a message that has done a big disservice for women, and it just starts from an early age.
It does start from an early age. I love that you said that, because you're absolutely right. The rhetoric around getting your period, hormones, perimenopause, it needs to continue to change. And a cultural paradigm shift has to continue to happen with that.
And we as healthcare providers have to take some responsibility here that, when the initial results from this big trial back in late 1990s, early 2000s came out, that really just abruptly caused us to stop, prescribing and using hormone therapy for the vast majority of people. We really didn't have any other great options. We didn't really put any research funding into really looking at what to do. menopause affects 51% of the population, and we didn't have other resources ready and put an investment in women at that for this stage of life.
And just to be clear, that research has since been debunked.
It's been reanalyzed
Okay.
ad nauseum, and really the information, for instance, the 25% increase in breast cancer that was published from that original assessment of the trial that stopped that arm of the trial in 2001, it has been totally reevaluated, and it's not that high percentage that people think it is. It's actually a very small amount. And interestingly, in their estrogen arm, which was a synthetic estrogen, not even the bioidentical one we're using now, the breast cancer rates in the people on estrogen only had lower breast cancer. So, our observational studies that we have now to draw upon have shown, really a lot of safety with using, especially transdermal, the estrogens, those sorts of things. So, sort of circling back to this whole idea that, that things are broken, a whole market stepped into that, right?
Sure.
And what we didn't offer as professionals has been really taken over by others, and all kinds of supplements and ideas of other sorts of treatments that may or may not have strong scientific evidence behind them. So, we own this as much as anyone else, that we haven't really had good options, but there is definitely a movement now to change this.
Yeah, that's amazing, and we'll keep working at it. I like how you said, so if we go back a little bit, you mentioned people coming looking for possibly validation of perimenopausal symptoms, but then from your perspective, analyzing and saying what's really driving this. Is this a sleep, a nutrition? Is it the lifestyle medicine component? And then deciding where to intervene. Is it some sort of hormone replacement, or do we need then, is the driving factor more the stress in that person's life? And then I think from a medical professional standpoint, the biomedical system is set up so that there's not time to sit down and say, listen, I hear you. I really think, based on what you're telling me, that stress is throwing a lot of this kind of out of whack. Would you be open to some stress counseling and try that for a couple months before we go into suppressing your ovaries? Or if we think that that's it, or how about let's do some sleep training and get you on a regular, kind of get that circadian rhythm back on track, and then reevaluate and see where things are at, versus just jumping to, this is my perimenopausal symptom, I want intervention for it. And I think that as an individual who's in that perimenopause kind of area of life, I can see where that would be really confusing. I have the information to sift through that in my head to say, oh yeah, okay, I need to sleep, and okay, I've tried this, and this, I still need something. I'm gonna go ask you for something. But I don't think that the general population has that information, and they need a medical provider to sit down and help them think through that in a way that still validates what they're feeling.
Sure. Would
that be a fair kind of, I know that was long-winded, but it was kind of this aha moment to me of, oh yeah, there's all sorts of overlapping symptoms here.
There are. And our approach is to try to look at that whole system, and which also includes sexual health. We haven't even touched on that.
Yep.
But look at what are those other mitigating factors, and oftentimes those are the really hard work ones. Almost everybody comes in with a frustration of weight, right? We know that women midlife gain kind of up to about 17% of their total body weight just happens midlife. And the idea that we should be calorie restricting and only doing cardio and those sorts of things, we've done sort of a disservice to people on that. So sort of looking at people's exercise patterns and their nutrition patterns, and less focus on the number on the scale than that, how do I feel 0 to 10?
Yeah.
How strong am I 0 to 10? Like those numbers. Where am I at with those sorts of things? Because long term, that's what's going to save us as older women, and having that eye on, where we want to be in our 80s and 90s. And that takes the work in perimenopause to think about that. So, I think we're able to help people with a lot of the, just the way our sort of society is, healthcare is set up, and being more, here's a medical treatment, here's a pill, here's a thing. I think we don't have as many resources as we'd love to all see, and maybe the resources are there, but are they competent? Can people get their health coverage to pay for them, to help with those really harder kind of pieces that it takes to sort of be your best self?
Yeah. Well, I feel like we could go on for a couple more hours back and forth. We should probably save some for your talk, and then we could still probably go on for a couple more hours after that. So one more question. So one of these, or some of the perimenopausal symptoms, can be quite concerning if they're not because of perimenopause. So how do we differentiate and kind of pull out some of these red flags? I mean, I think of when I was going through, and still am, the forgetfulness, the word finding. When it first started happening, I was like, I'm getting early onset Alzheimer's. What is wrong? Am I having a brain situation happening? And then I read a book. I read the Menopause Manifesto. And that was right before you started the menopause clinic. And I remember my chart messaging you, and I said, I have questions. I just read a menopause book, and I think I have all the symptoms in the perimenopause. Maybe I need help. So, but for me, then I was like, oh, aha, that's I'm not having a major neurological event. How do we know?
I read somewhere that the most common age that a woman sees a neurologist is age 51. Right?
Coincidence.
So, we definitely know there's some changes in cognition that happen around this time. And so, I think with all these things, teasing out the, is the fatigue, is this just sleep interruption, change in sleep that naturally occurs with age? Is this something cardiac going on? Is this something with the thyroid? So, we will do some baseline labs to kind of look at some things. We're looking at people's, vital signs and looking at their blood pressure and, working, in tandem with their primary care. Yesterday, I saw someone who, fatigue came up for her. And, as I looked back, her blood pressure was high yesterday. I looked back and I said, this has been high for a little bit. And, I think you probably need, this is not in my gynecology wheelhouse to investigate, but I think I'd like you to schedule with your primary care physician for this particular, we sort of worked through where her sleep is at. And
you're screening the systems.
We're screening
which
the
you
systems.
Need to, yes.
Yes. So again, sort of that careful listening, doing some baseline blood work, or making those referrals as we need to our endocrinology friends, those kinds of folks, to just help us sort through what could be other issues.
Okay, awesome. I love it. So anything else we should know in preparation? You want to leave us with any final thoughts?
I guess that, if people have specific questions, that would be very helpful in guiding sort of what I would be presenting, and making sure I give people the answers that they're looking for. So if they can reach out to you and let you know, like, what about this, then I want to make sure that I come prepared to have that and get that answered.
Perfect. And if you go to the website, ptemotionmatters.com, and then you click on the community tab, Laura's picture will be there, and you just click on that, and it'll take you to a form to fill out to register for the event. It's free next month, and feel free on that form, you can write your questions. So write any questions you have about menopause, and we'll start perimenopause, menopause, we'll start collecting them. All right, well, thank you so much for your time,
Yes.
and we'll leave it with that, and we'll look forward to seeing you next month.
Great. Thanks, Natalie.